Welcome to the deep dive. We sift through the information overload to bring you what really matters on today's topic. And today we're looking into a condition that, well, it mostly shows up on the skin, but it's got this hidden depth, often much more complex than just a standard rash.
Exactly.
Our goal today is to unpack cutaneous lupus erythematosus, CLE for short. We want to explore all its different forms, figure out how it's diagnosed, and understand its really critical connection to systemic lupus erythematosus, SLE.
And it's not super rare either. We're talking maybe 4 or 5 cases per 100,000 people.
Yeah, and it really affects women much more often, doesn't it? Like up to 8 times more than men, especially during childbearing years.
That's right. And what's really interesting, I think, is how it gets started. It's this complicated mix. You've got your genetics, right, your predisposition, but then environmental factors come into play.
Like what kind of factors?
Well, UV light is a huge one, sunlight, but also certain drugs, smoking, that's a big one. We'll come back to maybe even some viral infections. They can all sort of flip a switch in the immune system, making it target the skin.
Okay, so it sounds like a journey. We'll look at the types, the diagnostic tools. You mentioned something called CLASI.
Yep, the GlycosI score, crucial tool.
Right, CLASI. And treatments, and really hammering home why getting an early handle on this is just so important for you, the listener. Okay, let's unpack this then. You said CLE isn't just one thing, it's a spectrum. How does that actually look? I mean, for someone experiencing it, what's the variety like?
That's a great way to put it, a spectrum. And you see that spectrum right away when we talk about the main types. Let's start with acute cutaneous lupus erythematosus, or ACLE.
ACLE?
So ACLE is often, well, transient. It can come and go. But here's the key thing. It's very strongly linked to systemic lupus, to SLE. Over 80% of people with ACLE might eventually develop systemic symptoms.
Wow, 80%, that's high.
It is. It often flares up when the systemic lupus itself is flaring. Clinically, you might see that classic butterfly rash.
The Miller rash, right.
Exactly, the Miller rash. It's this redness, sometimes a bit of swelling, spread symmetrically across the cheeks and the bridge of the nose. And a really helpful clue, it usually spares the nasolabial folds.
Ah, those lines running down from the nose?
Yeah, precisely. It tends to stop short of those creases. It's very photosensitive, so sun makes it worse. The good news is it usually heals without leaving traditional scars, but it can sometimes leave behind changes in skin pigment, lighter or darker patches.
Okay, so ACLE, the butterfly rash transient, maybe no scarring, but a huge red flag for potential systemic involvement. That definitely sounds like something needing quick attention. But you said spectrum, so not all CLE is like that. What about the ones that stick around longer?
Right, exactly. Not everything is that acute picture. So moving along the spectrum, we have subacute cutaneous lupus erythematosus, SCLE. Think of this as kind of an intermediate form.
Intermediate how?
Well, it's also very photosensitive, but the lesions are typically non-scarring. That's a key difference from some other types. And it tends to show up in 2 main ways.
Okay.
You might get papulosquamous lesions. These are like reddish bumps with a fine scale on top. Sometimes they can look a little bit like psoriasis, or you might see annular or polycyclic lesions.
Annular, like rings.
Yeah, exactly. Ring-shaped lesions, often with raised edges and the center clearing out. Sometimes they look like connected rings, polycyclic, and you could actually have both types at the same time.
And where do these tend to appear? Still sun-exposed areas?
Mostly, yes. Very characteristic distribution, upper back, shoulders, the outside of the arms, the V area of the neck and chest, sides of the face. But importantly, it usually spares the knuckles and the central part of the face, unlike the ACLE butterfly rash.
Interesting. And does SCLE link to anything specific, like antibodies?
It does, very strongly. About 70 to 90% of people with SCLE test positive for anti-RASA antibodies. That's a really significant marker for diagnosis.
70 to 90%, okay.
Yeah. And while the risk of developing systemic lupus is lower than with ACLE, it's still there, maybe around 15 to 20%. We also know some drugs can trigger SCLE, like hydrochlorothiazide, a common blood pressure med, and terbinafine, an antifungal.
Right. So SCLE is sort of the middle ground, sun-sensitive, usually no scars, specific antibody link, lower but still present systemic risk.
Okay, so what's the type that really causes the long-term permanent skin changes?
That would be chronic cutaneous lupus erythematosus, or CCLE. And the main player here, the most common form by far, maybe 80% of CCLE cases, is discoid lupus erythematosus.
DLE, discoid. Okay, what makes that one stand out?
DLE lesions are, well, quite distinct. They're usually well-demarcated plaques, meaning they have very clear edges. They're red, they're scaly, and they have this feature called follicular plugging.
Follicular plugging, what's that like?
It's like the hair follicles get clogged up with scale. And if you were to gently lift off one of those scales, sometimes you see these little projections on the underside that were stuck in the follicles. It's called the carpet tack sign. Carpet tack sign. Wow, that's specific.
It is. It's a classic finding. But here's the really crucial part about DLE. It causes scarring, permanent tissue damage.
Ah.
It happens on the scalp, for instance. It leads to irreversible alopecia, permanent hair loss in those areas. This is why early diagnosis and, frankly, aggressive treatment are so vital for DLE. You want to prevent that long-term cosmetic and functional impact.
That makes sense. Scarring is a whole different ballgame. Does DLE have a high risk of going systemic?
The risk is lower than ACLE, but it's definitely there and depends on how widespread it is. For DLE that's localized, maybe just on the head and neck, the risk of progressing to SLE is around 5 to 10%. But if it's generalized, affecting skin below the neck too, that risk jumps to maybe 20 or even 30%.
So even the chronic skin-focused form still carries a risk, especially if it's widespread. That carpet tack sign really signals something serious then. It's not just appearance, it's preventing lasting damage.
Absolutely. Prevention of damage is the name of the game with DLE. And just briefly, there are a couple of other less common CCLE types.
Okay.
There's lupus erythematosus tumitis, or LET. This one looks different, more like raised, juicy, almost hive-like plaques. But importantly, there's usually minimal surface change, like scaling, and little to no scarring. It's extremely photosensitive, though, but very rarely linked to systemic disease, less than 5%.
Okay. Tumitis, swollen, but no scarring.
Right. And then there's lupus paniculitis, sometimes called lupus profundus. This affects the deeper fat layer under the skin. It shows up as firm nodules deep down. And when they heal, they often leave behind these deep depressions or dents because the fat tissue has been destroyed. That's called lipoatrophy.
Wow, so that leaves permanent indentations. Okay, so across the spectrum, we've got rashes that come and go, rashes that look like rings, rashes that scar deeply, even ones that affect the fat underneath. And always that underlying question about systemic risk. It must be tricky putting it all together for a diagnosis.
It really can be. And that leads to, how do clinicians actually sort this out? How do they confirm what type it is and track how you're doing? It's not just about looking at the rash, although that's the first step to characteristic clinical morphology.
Right, what it looks like.
Exactly. Then a skin biopsy for histopathology is usually essential. Under the microscope, there's a hallmark finding called interface dermatitis. Basically, the immune cells are attacking right at the junction between the epidermis, the top layer of skin, and the dermis below it.
Interface dermatitis, okay.
Yeah. And the pattern can differ between types. Like in DLE, you often see a lot of inflammation packed around hair follicles and sweat glands, plus that thickened top layer of skin. Gives us important clues.
Makes sense. What else besides the biopsy?
We also look at immunological markers in the blood, things like autoantibodies. ANA is a common screening test. Anti-dsDNA is more specific for SLE. And as we mentioned, anti-RASA is really strongly linked to SCLE.
The antibody tests. Got it.
And sometimes we do direct immunofluorescence on a skin biopsy. It's also called the lupus band test. This looks for immune proteins like IgG, IgM, or C3 deposited right at that dermal-epidermal junction. Seeing those can help confirm lupus is the cause.
Okay, so you combine the look of the rash, the biopsy results, the blood test, maybe that special fluorescence test. But once you have the diagnosis, how do you measure it? Like, how do you know if someone's getting better or worse objectively?
That is exactly where the CLASI score comes in. It's a really valuable tool.
CLASI. Okay, tell us about that.
CLASI stands for Cutaneous Lupus Erythematosus Disease Area and Severity Index. It was developed back in 2005, and it's pretty much become the gold standard now, both in clinics and research.
Gold standard. So what does it actually measure?
It gives two main scores. First, there's an activity score. This measures the active parts of the disease, things like redness, scaling, any involvement of mouth or nose linings, recent hair loss that's not permanent scarring yet. That score goes from 0 up to 70.
Okay, activity. What's the second score?
The second is the damage score. This captures the permanent changes left behind, stuff like changes in skin color, despigmentation, actual scarring or thinning of the skin, atrophy, hair loss that is permanent, scarring alopecia, and those deep dents from paniculitis. That score goes from 0 to 56.
Activity and damage. So how do you use those numbers? What's meaningful for the patient?
Yeah, great question. A change of 4 points or more in the activity score is considered clinically significant. So if your activity score drops by 4 points, that's a sign the treatment is working well. If it goes up by 4 points, that suggests a flare-up.
4 points. Okay, that's a concrete target.
Exactly. It gives everyone, your dermatologist, your rheumatologist, a clear, objective way to track things. Is the disease active? Is the treatment helping? Is damage accumulating? It really standardizes the assessment.
And you mentioned damage can increase even if activity goes down.
That's a really critical point. Yes, you might get the inflammation under control with treatment, so the activity score improves. But if damage has already occurred, or continues to occur slowly, the damage score can actually stay the same or even worsen over time. It really underscores why jumping on treatment early is so crucial to prevent that irreversible damage score from climbing.
Right. Stop the damage before it starts or it gets worse. Okay, so we can identify it, we can measure it with class I. Now the big one, how do we manage it? What do we do about it? And how do those triggers we talked about earlier fit in?
Management is key, and it starts with those triggers. We absolutely know that ultraviolet radiation sunlight, tanning beds, is a major, major trigger for flares in probably 60 to 90% of people with CLE.
Wow, that high.
Yeah, it's huge.
Yeah.
Genetics obviously play a role. We can't change that. But lifestyle factors like smoking, we know that's bad. And certain medications can trigger it. So awareness is step one. And because of that potential link to SLE, you always need to be watching for potential early warning signs of systemic involvement.
What kind of signs should someone be aware of?
Things like new joint pain or swelling inflammatory arthritis, new hair thinning all over, or sores inside the mouth, getting much more sensitive to the sun than usual. Or those general feelings of being unwell, persistent fatigue that's not explained, fevers, losing weight without trying. Any of those warrant a conversation with your doctor. And remember, the risk varies a lot. ACLE highest, localized DLE lowest.
Okay, so be vigilant about systemic signs. Knowing UV is a huge trigger. What's the absolute first line of defense in management?
Without a doubt, photoprotection.
Mhm.
It is the cornerstone. Non-negotiable for everyone with any form of CLE.
So more than just regular sunscreen use.
Oh, yeah. We're talking broad-spectrum sunscreen, SPF 50 or higher, and critically, one with high UVA protection. Physical blockers, the ones with zinc oxide or titanium dioxide, are often preferred because they block a wider range.
Zinc and titanium, got it.
And you need to use it correctly. Apply it generously 15-30 minutes before you go out. Reapply every 2 hours, minimum, and more often if you're swimming or sweating. Use enough about a shot glass amount for your whole body.
A shot glass full? That's probably more than most people use.
Probably. And it's not just sunscreen. Physical barriers are essential. Wide-brimmed hats, think at least a 3-inch brim. UV protective clothing, look for a UPF rating of 50 plus soon. Long sleeves, pants. Seeking shade, especially during peak sun hours, roughly 10 a.m. to 4 p.m.
So a whole sun avoidance strategy, really.
Pretty much. And even indoors. UVA rays can come right through window glass, so UV filtering films for home and car windows can actually make a difference for some people.
Wow, even indoors. Okay, and you mentioned smoking earlier?
Yes, this is critical. Smoking significantly reduces how well antimalarial drugs work. If you smoke, your response to medications like hydroxychloroquine might be 2 to 3 times worse. It's a major reason we strongly, strongly advise quitting.
Okay, that's a huge impact on treatment success. So photoprotection first, quit smoking. What about medications? You mentioned antimalarials.
Right. Antimalarials are really the gold standard systemic therapy for CLE. Hydroxychloroquine brand name Plaquenil is common, is usually the first choice, typically 200 to 400 milligrams daily.
Hydroxychloroquine. Okay. Are there downsides or things to watch for?
The main thing is a very small risk of damage to the retina in the eye, which can affect vision. It's rare, especially at standard doses, but because it can be serious, regular eye checks are mandatory. You need a baseline eye exam before starting or shortly after, and then usually an exam every year.
Annual eye exams, that's important. Does it work quickly?
No, it takes time. That's another key thing for you to know. You might start feeling some benefit in 6 to 12 weeks, but it can often take up to 6 months to see the maximum effect. Patience is needed.
6 months for full effect, okay? And what if that doesn't work well enough?
There's a sort of algorithm. For mild or limited disease, we might start with just topical things, steroid creams or ointments, or calcineurin inhibitors, which are non-steroid options.
Yeah.
If it's more moderate to severe or doesn't respond to topicals, that's when hydroxychloroquine comes in. If that gives only a partial response, sometimes another antimalarial called quinacrine is added. If hydroxychloroquine doesn't work or isn't tolerated, switching to a different antimalarial, chloroquine, is another option, though it requires even closer eye monitoring.
So, a stepwise approach. It feels like we often focus heavily on the clinical signs, the scores, the medications, but these conditions, especially visible ones, must have a huge impact on just daily life, right?
Oh, absolutely massive. And that's something we really need to emphasize. The quality of life, or QOL, impact of CLE can be profound. It often affects people more deeply than many other skin conditions.
Why is that? What makes it so impactful?
It's a combination of things. The lesions are often visible, right? On the face, scalp, arms. There's the chronic nature. It doesn't just go away quickly. It's unpredictable with flares. There can be physical symptoms, itching, burning, pain, sometimes functional limits, like if DLE scars cause tightness. And then there are side effects from medications. All of this takes a toll.
I can imagine. What kind of tool are we talking about?
It hits on multiple levels.
Yeah.
Physically, obviously. But psychologically, the rates of depression are high. Maybe 30 to 50% of patients report symptoms. Anxiety is common too. Poor body image, lower self-esteem, and that constant worry about it getting worse or progressing to systemic lupus.
That sounds incredibly stressful.
It is. And then there's the social dimension. People might feel stigmatized, withdraw socially, face limitations at work, or find it impacts relationships. It's really far-reaching.
So acknowledging that QL impact, what can actually be done to help? Beyond just treating the skin lesions.
That's where a holistic approach comes in. Practical things can help, like teaching techniques for medical camouflage makeup to help cover visible lesions if someone wants that. Providing psychological support is huge cognitive behavioral therapy, connecting people with support groups. And comprehensive education about the disease empowers patients.
So it's about treating the whole person.
Exactly. The real kind of aha moment, I think, is realizing that improving your quality of life shouldn't just be a side benefit of treatment. It should be a primary goal, a primary outcome we measure and strive for in managing CLE.
Treating the person, not just the skin condition. That feels like a really important shift.
All right.
Okay, looking forward now, what's on the horizon? What's exciting in terms of research and future treatments?
Things are definitely moving forward, which is great news. On the therapeutic frontiers, we're seeing a lot of interest in targeted therapies, especially biologics.
Biologics, like the ones used in other autoimmune diseases.
Precisely. For example, drugs that target the type I interferon pathway. Interferon is known to be overactive in lupus. Anifrolumab is one such drug. It's already FDA approved for systemic lupus, and trials are showing it can be quite effective for the skin manifestations too, so for CLE.
Okay, targeting interferon. What else?
JK inhibitors, these are small molecule drugs, often pills like baricitinib or tufacinib. They block signaling pathways inside immune cells. Also, drugs targeting B cells, which make antibodies like belimumab, which is also approved for SLE. Its role in isolated CLE is less clear, but it might be helpful, especially for ACLE linked to systemic disease.
And beyond biologics.
There are other novel small molecules being investigated. Things like BTK inhibitors and ROCK inhibitors. ROCK inhibitors are interesting because they might potentially help reduce scarring, which would be huge for DLE.
Reducing scarring would be a game changer. It sounds like these new approaches represent a shift in how CLE is managed overall.
Definitely. We're seeing several big paradigm shifts. One is the move towards precision medicine. The dream is to use molecular profiling, maybe looking at gene expression or specific biomarkers in a patient's skin or blood, to predict who will respond best to which treatment, or who's at higher risk for scarring or systemic progression, tailoring therapy to the individual.
Personalized treatment. Makes sense.
Another shift is the treat-to-target approach. Using validated tools like the Cutaneous score, we can set specific goals for treatment, like aiming for a low activity score or preventing further damage, and then adjust therapy systematically based on whether those targets are being met.
More proactive, data-driven management.
Exactly. And underpinning all this is the growing recognition of the importance of early intervention. Getting effective treatment started promptly, especially in potentially scarring forms like DLE, might not only prevent irreversible damage, but could potentially even alter the long-term course of the disease.
Catch it early, treat it effectively, maybe change the outcome long-term.
That's the hope. And finally, we're seeing a real push towards collaborative care models. CLE often sits at the intersection of dermatology and rheumatology, integrating care between specialists, maybe bringing in primary care, ophthalmology for eye checks, mental health support, providing comprehensive, coordinated management is really the future.
That integrated approach sounds crucial. It really seems like while CLE is definitely complex, the understanding and the toolkit for managing it are getting much, much better. There's real hope there. Okay, so let's wrap up this deep dive. We've learned that cutaneous lupus erythematosus isn't just one thing. It's a whole spectrum of autoimmune conditions affecting the skin. Some forms are strongly linked to systemic lupus, others less so, but early diagnosis and the right management plan are critical for everyone. We covered a lot of ground, didn't we? From recognizing the different phases of CLE, the the butterfly rash of ACLE, the non-scarring rings of SCLE, the potentially scarring plaques of DLE, to understanding how the Achilles size score gives us that objective measure of activity and damage.
Yeah, and we really emphasized the fundamentals, didn't we? That absolute necessity of rigorous photoprotection, the vital role of antimalarials like hydroxychloroquine, remembering those eye checks, and the fact that quitting smoking can dramatically improve treatment success.
And importantly, shifting the focus to include quality of life not just as an afterthought, but as a central goal of treatment, taking that comprehensive whole-person approach.
If we step back and connect this to the bigger picture, looking at CLE this way as a spectrum, with shared mechanisms, overlapping features with systemic disease, it kind of challenges us to think about autoimmunity differently. Maybe less as completely separate boxes and more as a continuum of immune system issues.
That's interesting. What other conditions might benefit from that kind of interconnected view? And what does that mean for how we even define disease?
Exactly. It makes you wonder, doesn't it? Perhaps seeing these connections could lead to new diagnostic approaches or treatment strategies across different autoimmune conditions. It pushes us towards a more nuanced understanding.
A really provocative thought to end on. Think about the ripple effects of visible conditions and the power of care that truly looks at the whole picture, physical, mental, social. We hope this deep dive gave you valuable insights into CLE. Thanks for joining us.